Hi guys, my name is Carrie Gilstrap. I am a clinical rheumatologist and I'm also the director of the Office of Academic Success at OSU CHS. I gave this presentation a few weeks ago at the STAB Symposium for a group of internists and other medical professionals, and I was asked by Dr. Cook to do a recording for you all to discuss osteoporosis. So, of course, as a rheumatologist, one of the things that we deal with commonly is osteoporosis evaluation and management. And so I wanted to update you all on what's happening in the world of osteoporosis in the year 2020 and go through some facts. Commonly in rheumatology, there are a lot of myths and rumors. One of my program directors in fellowship used to call rheumatology the study of rumors, and that's likely true. And osteoporosis happens to be one of those as well. And so there's a lot of misinformation about how to diagnose osteoporosis and also how to treat osteoporosis. And so that will be some of what we talk about today. So these are our learning objectives, which we'll go over. So there's a lot of osteoporosis guidelines, and the one that I'm going to focus for the purpose of this presentation is the guidelines that were introduced in 2016 by the American Association of Clinical Endocrinologists and the American College of Endocrinology, which are probably the most thorough list of guidelines. As you can see, there's a lot of other guidelines published by other societies and organizations, but these are the ones that we'll focus on today. Of note, the American College of Rheumatology traditionally has not published osteoporosis guidelines with the exception of glucocorticoid-induced osteoporosis, and we'll talk about some of those recommendations at the end of the presentation. So the first fact that we'll concentrate on is that osteoporotic fractures are not decreasing, but they are significantly increasing in the United States and throughout the world. And so we can see, looking at this graph, which was actually from quite a number of years ago, that the total number of hip fractures in the world is significantly increasing. And by the year 2050, we're expected to be introduced to this fracture tsunami, as the CEO of the International Osteoporosis Foundation called it, due to the increasing number of fractures worldwide. And this is due to lots of different factors, but primarily the aging population and also population growth in general. So by the year 2050, hip fractures are expected to multiply by a factor of 4, which is quite significant given that we already have a very large number of hip fractures. When we look at fractures in the United States, and again, this was from several years ago in 2005, there were a total of 2 million osteoporotic fractures. So these are all fractures that occur as a result of osteoporosis. The majority of those occur as vertebral compression fractures, as well as fractures of other sites, including the humerus, clavicle, tibia, and fibula. You can see about 15% of those are hip fractures. Some of those are Colles fractures at the wrist, and then pelvic fractures as well. And of note, which I think is really important, about a third of these actually occur in men. We'll talk about male osteoporosis later on, but that's something that I think we forget oftentimes, is that osteoporosis does occur in men, and the rates of osteoporotic fractures are increasing in men as well as in women. So when we look at fractures, we can see that fractures account for a greater incidence of healthcare related issues than things that we commonly think occur in osteoporotic age women, so older women. So things that affect older women we think of commonly are heart attack, stroke, and breast cancer, and those can significantly increase morbidity as well as mortality. But when we look at osteoporotic fractures, we can see that the rates of osteoporotic fractures are much higher than all three of those other things combined. And not only is the incidence higher, but the total cost is significant and is significantly growing. So just since the year 1998 until 2014, we can see that there was a huge increase in direct cost, the indirect costs that were attributed to osteoporosis. That's continued to increase significantly. So fact number 2, the majority of patients who sustain a hip fracture due to osteoporosis will never fully recover. And this is very significant. You can think of, I'm sure, plenty of patients that you've seen or family members or friends who have sustained a hip fracture, and you know that many of those patients never fully recover. So hip fractures are not the most common complication of osteoporosis, but they are the most serious consequence of osteoporosis. The majority occur in postmenopausal women, and the majority of these fractures occur from a simple fall. So when we think about hip fractures, you think it would take quite a bit of trauma to induce a hip fracture, but in osteoporotic bone, that's not true. In osteoporotic bone, most of these hip fractures occur from a simple fall, meaning that the patient's at a standing position and falls, and as a result fractures their hip. So it's not like they were up on a ladder fixing, a light bulb. They weren't, changing, they weren't, trying to fix shingle tiles on their roof or something like that. They were simply standing and then fell. So these are patients who are tripping over their dogs or their cats or a throw rug or a cord or something that could be easily in their way. Some of these patients have issues with gait and with balance. Both of those things do happen as patients age, and so as a result, patients have difficulty with balance, and as a result fall, putting them at much higher risk for hip fractures. Women with hip fractures have an increased mortality of up to 20% over the next 2 years. So a large number of women who fracture their hips do not live to be a year older or 2 years older as a direct result of that hip fracture. And the majority of survivors are actually unable to return to independent living. So when we look at men and women who have hip fractures as well as other fractures, we can see that the rate of Colles fractures kind of increases and then plateaus. Over time, the risk of vertebral fractures begins to increase and then, just slightly increases, but the risk of hip fractures really starts to take off around the age of 70 and significantly continues to increase throughout the patient's lifetime. On average, women who sustain a hip fracture are about 77 years of age, and by 80, about 15% of all women will have suffered a hip fracture. So when we look at the 1-year mortality and morbidity from hip fractures, we can see that as a result of hip fractures, about 24% of patients die. So about a quarter of patients actually die as a direct result of the hip fracture. Sometimes this is not maybe as apparent as it should be, because maybe the reason for death on the death certificate is pneumonia, but the patient actually became immobile and became sedentary and became maybe wheelchair bound as a result of their hip fracture, which subsequently put them at increased risk for infection like pneumonia, or on the same token, a DVT and a PE. These are sometimes listed as the cause of death, when in reality it was actually the hip fracture that precipitated these events to occur. About a third of patients are permanently disabled as a result of the hip fracture, and you can see 80% of patients are unable to carry out at least one independent activity of daily living 1 year after the fracture. So fact number 3, osteoporosis can be diagnosed with a T-score above -2.5. I think what we all recognize is this table from the World Health Organization, and this is what most of us commit to memory as far as what are the definitions for normal bone density, osteopenia, and osteoporosis. But the reality is that most patients who have a hip fracture or other low trauma fracture actually don't have an osteoporotic T-score. They actually have an osteopenic T-score. So what are other definitions of osteoporosis? So number 1, if the patient has had a low trauma spine or hip fracture, regardless of the bone mineral density, it may be -1.2, maybe -1.1, it doesn't matter. That's considered osteoporosis and can be coded as osteoporosis and should be treated as osteoporosis. The second one is patients who have osteopenia. So again, a T-score between -1 and -2.5, but they've had a fragility fracture of the proximal humerus, the pelvis, or the distal forearm. Again, these patients are now osteoporotic. They are no longer just osteopenic. And like I just said, the majority of fragility fractures do not occur in patients with osteoporotic T-scores. They occur in patients with osteopenic T-scores. And then the third category is patients who have osteopenia and a high fracture probability, which we'll talk about as well. The other thing to take into consideration is that if you see osteopenia reported on an x-ray report, so the radiologist, you do a chest x-ray in a patient and the radiologist says something about osteopenic appearing bones, or bone density appears to be osteopenic, by that point in time, about a third of those patients have T-scores that are already in the osteoporotic range, and about 50% of those patients have T-scores that are in the osteopenic range. So if you see that on an x-ray report, it means the patient's already lost a significant amount of bone mineral density and they need further evaluation for osteoporosis. So the FRAX, hopefully most of you are familiar with FRAX. FRAX was developed by the World Health Organization back in 2008. We use it all the time in clinical practice. It can be done easily at the bedside. Usually I'll do this while I'm talking to the patient in the room because there's some questions that they need to answer, and I'll plug these into this little online calculator, and then it will give me a calculation. But this is designed for patients who have osteopenia, so it's not designed for patients who are osteoporotic. We already know that they're at high risk for fracture, and those patients have to be treated. But this is designed for patients who are osteopenic, who have never been treated. And it can be used in women and it can be used in men. And basically what it gives you is a 10-year probability of hip fracture, as well as a 10-year probability of major osteoporotic fracture. And this can help guide your treatment recommendations and decisions. So who should undergo bone mineral density testing? So according to the American College of Clinical Endocrinology, all women who are over 65 years of age need bone mineral density testing, regardless of any other risk factors or any family history. In addition, all postmenopausal women who have either had a history of fracture without major trauma or have osteopenia that's identified radiographically, they need a DEXA scan. Other women who are peri or postmenopausal with risk factors for osteoporosis also need DEXA scans. So this would be women who are maybe not 65 years of age yet, but they're peri or postmenopausal, who have low body weight, patients who have been on long-term systemic glucocorticoids, and the definition of long-term is anything equivalent to a dosage of prednisone of 5 milligrams per day or more for 3 months or more. And this is cumulative lifetime exposure. So when you can think of all of the patients who you prescribe steroids to, think of how many patients would actually meet this criteria. Probably a very, very large number of them would. Any patient who is peri or postmenopausal who has a family history of an osteoporotic fracture, any patient who's peri or postmenopausal who went through menopause before the age of 40, who is a current smoker, or who has excessive alcohol consumption, which is defined as anything over 3 glasses of wine per day, should undergo additional testing for osteopenia or osteoporosis. And then all patients who have risk factors for secondary osteoporosis as well. So when we look at when women and men achieve peak bone mass, we can see that for women, the peak bone mineral density at the femur is attained sometime in the 20s. So early 20s, mid 20s, that's when women attain peak bone density at the femur. When we look at the spine and the forearm, that's going to happen around the age of 30. Bone loss starts to begin after that. So it actually starts before menopause. I think most of us think about menopause happening around the age of 50. You can see that by then, bone loss has already started to happen. Usually happens around the age of 40, which is depressing for me the older I get. So this is why we need to start screening these patients earlier and being more aggressive, because by the time we're screening them, most of them have already started to lose a significant amount of bone density. The same thing you can see happens in men, but it happens at a much later age in men, and it's a more steady decline. So how do we measure bone mineral density? So the most important risk factor for a future fracture is actually if a patient's had a prior fragility fracture. But if they haven't had a prior fragility fracture, the next most important predictor of a future fracture is by obtaining bone mineral density measurements with a DEXA scan. So the American College of Clinical Endocrinology and the World Health Organization diagnostic criteria for osteoporosis only apply to axial measurements. So I know that these scans tend to be popular. They're called peripheral DEXA scans. They can be done at the ankle and the foot, or the hand and the wrist. They're relatively cheap, they're convenient, they're inexpensive, but they don't give you great measurements. So if a patient does have a low bone mineral density reading on one of these machines, they really need further evaluation with an axial measurement on a central DEXA scan. Routine bone mineral density measurements, if at all possible, really need to be done on the same machine. There is some inter-machine unreliability that can happen. So please send patients back to the same facility where they've had DEXA scans. Sometimes I know machines are changed out for newer models. That happens, but trying to get the bone density measurement on the same machine is really important. And really the 3 sites that should be looked at are the femoral neck, the total hip, and the lumbar spine. If for some reason a patient cannot have any of those sites done because maybe they've had bilateral hip replacements and then they also have severe osteoarthritis of their spine, you can also use the distal 1/3 of the radius. Also, some patients are obese and their body weight will not allow them to be able to be positioned on the central DEXA scan machine. So because of that, sometimes you need to also consider using the distal 1/3 radius, which is an acceptable site if needed. So fact number 4, all women with osteoporosis should be screened for secondary causes. So we know that at least 40% of women with osteoporosis actually have a secondary cause. So this is really important to consider. Most of the time it's like vitamin D deficiency, but these are the rest of the labs that are currently recommended in these patients with osteoporosis. So this would include a CBC, a complete metabolic profile, intact PTH, a phosphate, as well as a 24-hour urine collection for calcium, sodium, and creatinine. And note that this needs to be done only after the patient's been on a vitamin D replacement and has had adequate calcium for the past 2 weeks. Also, in certain patients, you need to consider checking thyroid studies, celiac antibodies, as well as studies for myeloma. So the list of secondary causes is extensive, but I think when you start to look at these, you realize that you have a lot of patients and you've seen a lot of patients previously maybe who have fit into one of these categories. And so these are the things that we just need to keep in mind, that lots of patients are at risk for osteoporosis, not just postmenopausal women. So fact number 5, bone loss and osteoporotic fractures are preventable. And that's one of the key messages I think we need to get across, is that we're not just treating hip fractures, we're trying to prevent hip fractures. So one of the ways we can help prevent fractures is with calcium and vitamin D. For patients who are not vitamin D deficient, they need at least 1,000 international units of vitamin D3 every day. So this is applying to adults over the age of 50. The safe upper limit of normal is about 4,000 international units per day. Of course, patients who are vitamin D deficient need much higher dosages. The effectiveness of osteoporotic medications may be hindered by vitamin D deficiency. So that's important to remember for patients who are on bisphosphonates and other medications for osteoporosis. They really need vitamin D replacement so that those medications can be effective. The optimal vitamin D level needs to be above 30. There's a lot of controversy still about what this actual number needs to be, but we know that the reasonable upper limit of normal is about 50, and really toxicity is not seen until the number is greater than 150. And so you actually can, get this number probably higher than 50 without worrying about toxic side effects, although the current reasonable upper limit of normal still is around 50. So what about calcium? So the total daily intake for calcium is recommended to be about 1,200 milligrams for all women over the age of 50. And this is endorsed by multiple societies and organizations. Several years ago, there was an article published showing that the rates of atherosclerosis were actually increased in patients who were taking high doses of calcium. We also know that that's seen in patients who have very low calcium intake. So the current recommendations are total daily intake, total meaning calcium from diet and calcium from supplements, about 1,200 milligrams per day for women over the age of 50. Just with calcium alone, the studies have shown that there is a slight increase in bone mineral density. There's been mixed results in studies as far as how efficacious calcium is for reducing fractures. So again, dietary calcium may be preferred over calcium supplements, particularly if there's a concern for cardiovascular disease, and the total calcium intake should not exceed 1,500 milligrams per day in women over the age of 50, primarily because of this possible increased risk of atherosclerosis. There are two standard forms of calcium. One's calcium carbonate. This is the form that you find most commonly in pharmacies. It's less expensive. Patients don't have to take as much to get the adequate recommended dosing, but it does require gastric acid for absorption. So probably not a great choice in someone who has GI side effects from calcium, or someone who's had surgery that may impair gastric acid production. Calcium citrate is more expensive. Patients have to take more tablets to get the recommended dose, but the absorption is not dependent upon gastric acid, so it may be a good choice for patients who have GI irritation with calcium carbonate. Lifestyle modifications are important as well. Excessive alcohol, of course, can lead to decreased bone formation because of multiple mechanisms. One of those, though, being calcium deficiency and chronic liver disease, which leads to vitamin D deficiency. Also, of course, it predisposes patients to falls. And the current recommendations are to consume less than 3 drinks per day. That's 3 glasses of wine, which is also equivalent to 2 cans of beer, or essentially 2 shots of liquor. Smoking, there's lots of mechanisms why smoking probably decreases bone density. Part of that may be because it increases metabolism of endogenous estrogens. Also, there's direct effects of cadmium on bone metabolism. And so cigarette smoking can significantly impair bone density because of these effects. Exercise is really important, especially weight-bearing exercise, as well as strength training and posture exercises for these patients. The improvements in bone density, reducing fracture risk, may be up to 10% in these patients who exercise by participating in weight-bearing activities on a routine basis. That's pretty significant in osteoporosis therapy. Also, of course, exercise improves muscle strength, and as a result may reduce fall risk. Okay, fact number 6, only about 10% of older women with fractures actually receive osteoporosis therapy. Every time I see these statistics, it's shocking, and really just, tells me that we're not doing a great job of treating these patients. We're not doing a great job of addressing osteoporosis, and we have to get better. So who needs treatment? Which patients actually need treatment for osteoporosis, low bone density, to reduce fracture risk? So any patient who is osteoporotic by T-score of negative 2.5 or lower needs treatment. You can't just let these patients continue on calcium and vitamin D. They need a medication that will help improve bone density. Any patient who's osteopenic and has a history of a fragility fracture of the hip or spine needs treatment. Remember, number 1, these patients are already osteoporotic. They're no longer just osteopenic because they've had a fragility fracture of the hip or spine. And remember, the second thing is the most important predictor of a future fracture is a prior fracture. So these patients are at extremely high risk for a second fracture. And then any patient who has a T-score in the osteopenic range and a high fracture risk based on the FRAX tool, which means their major osteoporotic fracture risk is 20% or higher, and their 10-year probability of hip fracture is 3% or higher. Again, these patients now have a definition of osteoporosis, and they need treatment, something other than just calcium and vitamin D. And then any patient who's had a low trauma fracture. So patients who have lost height, you do a chest x-ray, you see several vertebral compression fractures, those patients need treatment. So these are currently approved medications for osteoporosis. The last time I gave this talk before this most recent presentation earlier this month was a couple of years ago, when we actually only had 9 medications approved. But since that time, we've been able to add 2 more to our list. So that's really exciting because these are very potent agents for osteoporosis. So we are increasing options, which is fantastic. So we currently are up to 11 FDA approved treatments for osteoporosis. So what should we use initially? So initial therapy really needs to probably be something that's broad spectrum. So you want to use something that's been shown to reduce fractures at the hip and vertebral sites. And this would be either one of 3 bisphosphonates, either alendronate, which is Fosamax, or sindronate, which is Actonil, or zoledronic acid, which is reclassed, or denosumab, which is in a class all by itself. We'll talk about it a little bit later, but that's Prolia. These medications all have broad spectrum anti-fracture efficacy. If a patient has lower or moderate fracture risk, so we're talking about a younger woman who's postmenopausal, who hasn't had prior fractures, and only has moderately low T-scores, you could consider just using an oral bisphosphonate like alendronate or sidronate, maybe something that's not extremely potent, but something that will do the job. If a patient only has a high risk for spine fracture, they don't have a risk for hip or vertebral fracture because maybe the bone density is only low at the spine, you could consider ibandronate, which is Boniva, or raloxifene, which is Evista. These medications, however, have only been shown to reduce fracture risk at the spine. They've only been shown to improve bone density at the spine. So they're not broad spectrum like these other medications. So again, that's the only time I'd really consider using one of those medications. If a patient has a high fracture risk, so we're talking about older women who have already had several vertebral compression fractures, or they've already had a hip fracture, or they have very low T-scores. So we're talking about the patients with T-scores negative 2.9, negative 3, or they have upper GI issues. So they have chronic gastric irritation or severe GERD, or they have issues with chronic malabsorption. So maybe they have inflammatory bowel disease, or they have celiac, or they just can't remember to take their oral medications because of the recommendations for how they have to take bisphosphonates. Those are patients who would be most appropriate for injectable agents. So this would be things like denosumab, which again is a Prolia, which is a subcutaneous injection, or zoledronic acid, which is Reclass, which is an IV infusion, teriparatide, abaloparatide, romosozumab. We'll talk about all three of those. These are anabolic agents that are all given by injection. If a patient has renal insufficiency, the current recommended drug of choice is denosumab, which is Prolia. However, this medication still cannot be given to patients who are on dialysis or have stage 5 chronic kidney disease, and this is primarily due to the risk of hypocalcemia that can occur with this medication, particularly in these patients with renal insufficiency. So let's talk for a while about bisphosphonates. So bisphosphonates are called bisphosphonates because they have two phosphate groups. These medications work by binding to hydroxyapatite in bone, particularly at active sites of bone remodeling. So these are sites where bone is being remodeled. And the overall effect of bisphosphonates is to reduce the activity of osteoclasts. So these are anti-resorptive medications. There are currently 4 that are available in the United States. All of these are currently generic medications. So we have alendronate, risedronate, zoledronic acid, and then ibandronate. Again, these 3 have shown reduction in fracture risk at the spine and hip, and then ibandronate, Boniva, only has fracture risk reduction at the spine. If the medications are orally administered, so this would be alendronate, risedronate, or ibandronate. Ibandronate, there's 2 forms. One can be given oral, one can be given IV. But for the orally administered bisphosphonates, these patients have to take these medications very specifically. They have to be taken after prolonged fast, so typically first thing in the morning before they've eaten anything. They have to be taken with a full 8-ounce glass of water, and that has to be followed by a 30-minute wait. So they can't eat anything for at least 30 minutes or take any other medications or any beverages other than water for at least 30 minutes after they've taken the medication. These are really difficult instructions to follow, particularly for elderly patients maybe who have issues with memory. One thing to note is that Atelvia, this is a newer form of risedronate, Actonil. So there's a newer form called Atelvia. This is actually, it has a delayed release coating. And so this medication actually can be taken with or without food. So it actually can be taken with breakfast, which is kind of nice. It increases the compliance for this medication. However, if patients are having issues with GI irritation from oral bisphosphonates, it can still happen with Atelvia as well. So what are contraindications to bisphosphonates? So for oral bisphosphonates, of course, if a patient has an esophageal disorder, if they have an inability to follow the dosing requirements, if they've had a gastric bypass surgery because of the decreased gastric acid and the issues with malabsorption that may occur, these are patients who are not ideal candidates for oral bisphosphonates. For oral or IV bisphosphonates, patients who are hypocalcemic should not receive these medications until the hypocalcemia is corrected, and patients who have chronic kidney disease should not receive these medications as well, defined as a GFR of less than 30 to 35. The FDA has concluded that there's no definite association with esophageal cancer. There were several reports years ago about this, but there's no conclusive evidence that these medications lead to esophageal cancer. There is, however, a possible association with new onset atrial fibrillation, particularly with zoledronic acid reclass. And so this is something to be aware of in patients who are particularly elderly who may be at risk for atrial fibrillation. So what about denosumab? Denosumab is Prolia. It's a really unique medication because it's a human monoclonal antibody. The medication works by preventing rank ligand from attaching to the receptor, which is rank. And ultimately, with this interaction, the medication reduces the differentiation of precursor cells into osteoclasts, which leads to decreased function and decreased survival of activated osteoclasts. So denosumab is Prolia. It's also an anti-resorptive medication, but it is not a bisphosphonate. In general, it has a very, very good safety profile. There is a slight increased risk of serious infections because it is a monoclonal antibody, so you do not want to administer the medication to anybody who has an active infection. There have also been some reports of eczema that have been reported in clinical trials that have recurred as a result of Prolia. You have to correct calcium and vitamin D before this medication is administered. The medication can lead to hypocalcemia if this is not evaluated first. So all patients need calcium levels checked before you administer denosumab. There is an increased risk of vertebral fractures after the medication is discontinued. And this is something that's been reported just in the last several years. This medication's been around for a while. It significantly improves bone density. Patients really like it because it's given as a subcutaneous injection only twice a year. So the compliance is fantastic with this medication. However, if you stop the medication and you don't replace it with anything else, bone density can significantly begin to decrease, and patients become significantly at risk for vertebral compression fractures. So if the medication has to be discontinued, you really need to start these patients on an alternative agent, so something like a bisphosphonate or an anabolic agent. And again, particularly in patients with chronic kidney disease and malabsorption, you have to monitor calcium levels closely because of the risk of hypocalcemia. So other treatment options, I'll just briefly mention these. Raloxifene is a Vista. It has an FDA approval for the treatment of osteoporosis. Efficacy really has only been shown, though, in reducing spinal fracture. So it does not have broad spectrum anti-fracture efficacy. It is less effective than bisphosphonates. Really, you should only consider this medication for prevention of osteoporosis instead of treatment of osteoporosis because it is a weak anti-resorptive medication. And maybe only in particularly patients who have increased risk of breast cancer. So probably a really select small group of patients who this should be the treatment of choice for osteoporosis. Other treatments are much more effective. Calcitonin really has not been shown to significantly increase bone mineral density. It's a very, very weak anti-resorptive medication, really is only used for a short-term analgesic after a patient suffered a vertebral fracture. And then estrogen, I won't say much about this. Really, this should only be used if there are no other medications available because of the potential side effects associated with long-term estrogen therapy. Okay, so fact number 7, anabolic agents can be used in select circumstances as first-line agents. So this is something that I want to talk about because when we see things like teriparatide, which is Forteo, abaloparatide, which is Tymlos, and romosozumab, which is a new medication called Evenity, we think about only using these medications in patients who have extremely severe osteoporosis. They don't tend to get used very frequently, but there are times when these medications should be used as a first-line treatment. So instead of going right to alendronate, you should really go right to teriparatide if at all possible. So they are indicated as first-line treatment for postmenopausal women who are at very high risk of fracture. So what does that mean? That means patients who have a very low T-score. So these patients have a T-score of negative 3.5 or lower without a fragility fracture, or a patient who does have osteoporosis as defined by the World Health Organization guidelines, negative 2.5 or lower, and they've had a fragility fracture. So the patient who walks into my office who's had a hip fracture and the T-score is negative 2.5, that patient's probably going to be put on an anabolic agent because I know these medications are very effective, they work very quickly, and they significantly reduce the risk of future fracture. These patients are the highest risk for future fracture. Or if a patient's had multiple vertebral compression fractures. So you see an x-ray, they've already had 3 vertebral compression fractures, they probably need an anabolic agent, or you're just waiting for them to experience another vertebral compression fracture. Of note, teriparatide is the only one that's also indicated for male osteoporosis and glucocorticoid-induced osteoporosis at this time. These other 2 are fairly new to the market within the last 2 years, and so at some point in time, I'm hoping they receive similar indications as well. So let's talk about PTH and PTHRP analogs. So this is teriparatide and abaloparatide. So again, they're both approved for initial treatment for postmenopausal osteoporosis. Women who've had a history of osteoporotic fracture, have multiple risk factors for fracture, or are intolerant of prior osteoporosis therapies. The side effects are typically mild and very transient. In general, they're very well tolerated medications. They do have to be given as injections daily. They're very, very, very small needles that are given as subcutaneous injections by the patients themselves, and in general, very well tolerated. Osteosarcoma, that's one of the concerns I think that we think about now with teriparatide that everybody's concerned and worried about. The reality is this is an extremely rare side effect, really only seen in rats who were treated with extremely high doses of teriparatide, 3 to 50 times higher than the human dose for the lifetime of the rat. So very, very, very long time period of treating with teriparatide in a very, very, very high dosage. So the current recommendations are to only treat with these medications for 2 years, but to also avoid in patients who are increased risk for osteosarcoma. So this would be patients who have had prior skeletal radiation, they've had prior metastatic disease to the bone or prior bone malignancies, they've had Paget's disease of the bone, unexplained elevations of the alkaline phosphatase. If they're a child and have open bone epiphyses, you would not want to use this medication, or in pregnant women. You also want to avoid these medications in patients who have primary hyperparathyroidism or unresolved or untreated secondary hyperparathyroidism, since they are PTH or PTHRP analogs. And if you stop the medication, just like denosumab, the bone density is going to decline very quickly. So as soon as you stop these medications, and again, they can only be used for 2 years, you need to use an alternative treatment. So this is something that I think is always shocking to patients, is that this is what happens when you treat patients with an anabolic agent. This is showing a vertebrae from a patient who has severe osteoporosis. You can see the architecture of the bone is very, very thin, very fragile, very weak. And this is about 18 months after treatment with teriparatide. So significant improvement in bone density. The bone has actually increased in size. This patient is going to have a much lower risk of breaking that bone, having a fracture after treatment with teriparatide as a result of the anabolic effects of that agent. So let's talk a second about sclerostin. Sclerostin is a protein that's produced by osteocytes. Sclerostin's activity is mainly anti-anabolic. And so there is a condition that's relatively rare called von Buchan's disease. And this is an autosomal recessive condition of sclerostin deficiency. So patients who are homozygotic for the sclerostin deficiency have very, very, very high bone mass of very good quality. They have very low fracture risk, but what happens is they have cranial and bony overgrowth. So this is a typical kind of facies from a patient who has von Buchan's disease, where you can see the very enlarged mandible. This is a skull where you can see these bony overgrowths from a patient who has von Buchan's disease, as well as these mandibular overgrowths. And then here we're looking at a cranium, and you can see how thick this cranium is from the patient with von Buchan's disease compared to a patient without von Buchan's disease. In patients who are heterozygotic for this condition, they have a normal phenotype, except they also have this very high bone mass. So that's where this medication was essentially born. This is romosozumab, which is Evenity. This medication was FDA approved just about a year ago in April 2019. It is an anabolic agent. It is indicated for women with postmenopausal osteoporosis who have very high risk of fracture, and it is a monoclonal anti-sclerostin antibody. So a very new class of medication, a very exciting way to treat osteoporosis, and it's extremely effective. In addition to having anabolic activity, it also is very unique because it has anti-resorptive properties, which is really interesting and probably what leads to the very high bone mass that these patients will achieve after treatment with romosozumab. The current recommendations are to treat with this medication for 12 months. After 12 months, the effect kind of starts to plateau. And so treatment is started for 12 months and then discontinued, and then patients are transitioned to either bisphosphonate or denosumab. They cannot be treated with another anabolic agent after they've been treated with romosozumab. There was a cardiovascular safety signal that occurred in several of the trials with romosozumab, and currently this is a black box warning. This medication took years and years and years to get FDA approval. Most medications that are indicated for osteoporosis take years and years and years to get approval because it takes many years to show significant effects on bone density. However, this medication took extra long because of this interesting cardiovascular safety signal. The current recommendations are to avoid the use of this medication in women who have had a serious cardiovascular accident, or an event, either an MI or CVA, within the past year. Also consider avoiding this medication in women who have significant cardiovascular risk factors. This has been kind of a hindrance for this medication to really take off and become commonly used, because a lot of these patients we're treating are elderly postmenopausal women, and many of them already have cardiovascular disease. Common side effects of this medication are headache and joint pain. The medication is administered as 2 subcutaneous doses monthly. They have to be administered in a physician office by a healthcare provider. And again, the medication is only delivered for 12 months. There is no dose adjustment need in patients who have renal impairment, although just like patients who are taking denosumab, you need to be concerned about hypocalcemia and not treat patients who have significantly impaired renal function with this medication. And again, after you stop this medication, you need to transition these patients to another agent, because their bone mineral density will start to return to baseline and their fracture risk will start to increase fairly quickly after the medication is discontinued. Fact number 8, atypical femoral fractures and osteonecrosis of the jaw are rare side effects of osteoporosis medications. So these are extremely rare side effects, but reasons why patients don't take osteoporosis medications, and reasons why physicians are sometimes afraid to prescribe these types of medications. So let's talk about what ONJ truly is. So ONJ is an exposed necrotic bone that does not heal after 6 to 8 weeks of appropriate management. That's essentially the definition. It often occurs at sites of prior dental extractions or where patients have had very invasive dental procedures. In severe cases, it can lead to pathological jaw fractures, although this is rare. And the large majority, the vast majority of these cases of ONJ related to bisphosphonates occur in patients who are treated with bisphosphonates for malignancy. So typically when medications are used like denosumab or zoledronic acid in cancer therapy for metastatic disease to the bone, the dose is extremely high, at least 10 times higher than what we use to treat osteoporosis. So again, when we're looking at the cases for osteoporosis of ONJ, they're very, very small compared to the patients who develop ONJ as a result of bisphosphonate treatment or denosumab treatment for malignancy. Interestingly, also the main article that was published citing that these incidents were extremely rare was from the Journal of the American Dental Association. I think this is interesting because there's plenty of dentists who are concerned about this. We get letters from dentists and calls from dentists all the time stating that the patient cannot be on a bisphosphonate or denosumab because they may experience ONJ. However, it's this journal that actually cited that this was an extremely rare side effect and that osteoporosis is responsible for considerable morbidity and mortality. Therefore, the benefit provided by anti-resorptive therapy outweighs, in most cases, the low risk of developing osteonecrosis of the jaw, and discontinuing bisphosphonate therapy may not lower the risk, but may have a negative effect on low bone mass treatment outcomes. So I think this is something important. This is something that I often discuss with dental colleagues when they're concerned about treating a patient with a bisphosphonate who is at extremely high risk for fracture because of their concerns and fears of ONJ. So what can you do for ONJ? Well, typically the patients who are at the highest risk for ONJ or patients who have other risk factors. So patients who are also taking glucocorticoids, patients who are immunosuppressed, patients who have an active ongoing infection, particularly in their mouth, patients who have heavy microbial biofilm, or if they're diabetic or they're smokers, other conditions that may impair or delay wound healing. Typically, before you start an anti-resorptive medication, so something like a bisphosphonate or denosumab, you want to wait for all oral infections to completely resolve or be treated. You also want to correct poor fitting dentures, correct poor dental hygiene, and wait several weeks after the mucosal surfaces have properly healed before you start the medication. In addition, using chlorhexidine rinse before invasive procedures has been shown to reduce the risk of ONJ, so that's something that our patients can do and talk to their dentist about. If your dentist is really concerned, or if you're really concerned about the potential for ONJ, you can consider holding the bisphosphonate for a few months before and after very invasive dental procedures, although remember that the half-life of these medications, particularly bisphosphonates, is very long, and so this really may not be doing anything other than helping your dental colleague to sleep better at night, But if you must, you can consider holding the medication for a short period of time. And again, make sure just to ask patients about any upcoming dental work or any non-healing mucosal sites that they may have in their mouth that they may not disclose to you. So what about atypical femoral fractures? So atypical femoral fractures are unique because they're not what we typically think of as osteoporotic hip fractures. Osteoporotic femoral fractures typically occur in the trochanteric range, but when we talk about atypical femoral fractures, they're occurring at the subtrochanteric region, and they usually occur as a result of very minimal trauma. If any trauma. Sometimes there's no trauma associated with it. The incidence of atypical femoral fractures is directly related to the duration the patient's on a bisphosphonate, as well as their adherence to therapy. So the patients who are more compliant may have a higher incidence of atypical femoral fractures. Many of these patients will have a prodromal thigh or groin pain. So if they come in complaining of this constant annoying pain going on and they've been on a bisphosphonate for a while, go ahead and get an x-ray just to make sure that they're not developing a fracture. Sometimes you can actually see this beaking of the bone that typically happens as a prodrome to the actual fracture occurring. 30% of these can actually be bilateral. The absolute risk, though, remember, is extremely low. And if you need to share statistics with your patients, you can always tell them that for every one atypical femoral fracture that's caused by a bisphosphonate, there are at least 100 osteoporotic femoral fractures that are prevented by a bisphosphonate. So again, a very, very rare side effect. So what has happened as a consequence of, these side effects may be blown out of proportion. And so there was a New York Times article a couple of years ago stating that the fear of these drugs were side effects means that millions of patients are taking their chances with osteoporosis. We know that oral bisphosphonate use has declined by about 50% over the last 10 years. That's shocking. That's scary. That's probably going to lead to increased rates of osteoporotic fractures. Adherence to medications is declining because of these very rare side effects maybe being blown out of proportion. So we really need to balance the need for the medications with the very small potential risk of adverse effects from the medication. Fact number 9, what about drug holidays? A drug holiday may need to be considered with bisphosphonate. So let's talk about that for a second. So bisphosphonates do accumulate in the bone, and again, they have a very long half-life in the bone. So the current recommendations for patients who are very high risk, who remain at very high risk, are that if the patient's been on an oral bisphosphonate, maybe you consider limiting the treatment duration to 10 years. In that case, you may want to take the patient off the medication and consider an alternative agent, or maybe take them off the medication, monitor bone density very closely, and maybe consider putting them back on the agent. The patients who have been on IV bisphosphonate, so zoledronic acid or IV ibandronate, limit duration currently recommends to about 6 years of therapy. And again, if the patient remains at high risk, maybe they really should be transitioned to an alternative agent. For patients who are at lower risk, you can consider a drug holiday after 5 years of stability on an oral bisphosphonate or 3 years of stability on an IV bisphosphonate. During the holiday, typically no other treatment is needed, again, only for lower risk patients, but for higher risk patients, you really need to consider an alternative treatment. So an anabolic agent or maybe a weaker antiresorptive medication like raloxifene. And again, in some of these patients who are extremely high risk or have already had atypical femoral fractures as a result of long-term bisphosphonate therapy, monitoring bone density is going to be extremely important. So the optimal duration of drug holiday timeframe is not established, and you really need to consider resuming therapy in patients who experience a fracture or show significant bone mineral loss, bone mineral density loss while they are off the agent. So let's talk a little bit about osteoporosis in men. This is a subject that does not get much attention, and it really should. We think about osteoporosis being a female disease, and that is not true. Yes, there is a higher incidence in women, but yes, the disease also can occur in men, and because we're ignoring this, more men are experiencing fractures. So again, why is this happening? It's because of the aging population. So more men are living to older ages, just like more women are living to older ages. So when we look at North America alone, we can see what's happened since the year 1950 to 2000, and then what's projected to happen with the aging population of men by the year about 2050. So at that point in time, about 1/4 of all men will be over the age of 60. So we know that about 1 in 3 women over the age of 50 will experience an osteoporotic fracture in her lifetime. On the same page, 1 in 5 men will experience an osteoporotic fracture in his lifetime. So men do have higher peak bone mass, they do have larger bones and greater muscle mass, and they are less likely to fall. However, just like women, men experience a decline in the bone mineral density over time. Again, it doesn't happen to the same degree, and it happens at a later age, but it does happen. So in men, you really need to consider ordering a DEXA scan in men who were 70 years of age or older, and that's without any potential risk factors. Men who are younger, who've had a fragility fracture, these men must be evaluated for osteoporosis with a DEXA scan, and men who have risk factors also need to be evaluated for with a DEXA scan for low bone mineral density. A fracture or femoral neck T-score of -2.5 or less, again, identifies only a small number of men who will fracture. Just like women, the majority of men who have osteoporotic fractures have osteopenic T-scores. All men, just like women, need to be screened for secondary causes. So in addition to the list of causes we talked, or the list of labs that we talked about for women, men also need a testosterone level checked. Medication options for men are not as wide and broad as for postmenopausal osteoporosis, although most bisphosphonates are FDA approved for treatment in men. Denosumab, which is Prolia, is approved for osteoporosis in men treatment, and teriparatide, which is Forteo, is the only anabolic agent currently approved for male osteoporosis. The other thing that I think is really important to remember is that the mortality rate after a hip fracture is actually greater in men than it is in women. And there's lots of reasons why this probably is. But remember that men develop osteoporosis at a later age in life. So the men who have these hip fractures are going to be usually older than the typical woman who has a hip fracture. And because of that, they usually have significant other comorbidities. And this will increase their fracture or their mortality rate significantly. So I'll talk just a second about glucocorticoid-induced osteoporosis because that's an entirely different lecture in itself. But remember that glucocorticoids are the most potent risk factor for secondary osteoporosis. And think of all of those times that you're writing for prescriptions for IV corticosteroids or oral corticosteroids and patients who are on those medications at fairly high dosages for long periods of time. These patients are at very high risk for osteoporosis. So when we look at osteoporosis induced by glucocorticoids, we're always asking ourselves the age-old question: is there a safe dose? Is there ever a safe dose of glucocorticoids? Probably not, although we do know that the effects are significantly related to the cumulative exposure and the peak exposure. So you can see patients who take less than 2.5 milligrams of prednisone are at much lower risk for hip fracture and vertebral fracture than the patients who take over 7.5 milligrams of prednisone on a daily basis. The steroid effect on bone is immediate, but it is potentially reversible if the patient's only on the medication for a short period of time. So again, that's why it's really important to get these patients off steroids as soon as possible. So I'm not going to go over these in general, but these are really good guidelines, I think, to have available, particularly in the hospital setting, because we know these patients are oftentimes on glucocorticoids in the hospital setting and are often sent home on glucocorticoids for a while with a taper. So these are the recommendations that were introduced in 2010 by the American College of Rheumatology regarding the treatment for glucocorticoid-induced osteoporosis and the treatment recommendations for patients who do not have glucocorticoid-induced osteoporosis but are being exposed to glucocorticoids. So two different sets of recommendations here, but something that I think would be very helpful to kind of understand and to have handy. So this is just my summary slide. This was my grandmother. She died several years ago. She was extremely active, very, very, very healthy. She lived to the age of almost 97 and really didn't have significant health issues until later in life. One of those was severe osteoporosis. And unfortunately, she really didn't get screened for osteoporosis until she was in her 80s. She didn't get treated for osteoporosis until several years after that, despite having multiple risk factors for osteoporosis. She was always a very, very thin, petite woman. Both of her older sisters had severe osteoporosis. So my grandmother was eventually treated for osteoporosis, but really the effect was a little bit too late. And as a result, she did have multiple pelvic fractures. about 6 months before she passed away. And unfortunately, you know, part of her passing was as a result of osteoporosis. So I think we all have stories like this. We know people like this. We've seen patients like this. And again, just realizing that osteoporosis can not only be treated, but it can be prevented is really important. One of the other things to bring attention here is that only 25% of patients are screened for osteoporosis after they have a hip fracture. So these patients are in the hospital, they have a hip fracture, they undergo surgery, or they don't undergo surgery because maybe they're too high risk for surgery. But these patients have to be not only screened for osteoporosis, but they have to be treated for osteoporosis, because if you don't, they're going to have another osteoporotic fracture. And so again, realizing that osteoporosis is preventable and treatable is extremely important. Awareness is really key. Just remembering that osteoporosis is out there. You're going to see it a lot. If you're not seeing it a lot, you're missing it. So please, please, please evaluate for it. And that is all I have. Thanks.